Hello, good afternoon. Thank you for joining us for this afternoon's QTECH committee meeting. We'll be getting started in just a few minutes. Hello, thank you for joining us for this afternoon's QTECH committee meeting. We're going to get started in just a couple minutes, but we would love for you to participate in our live word cloud activity. So here are some instructions for you to participate in that. Today's live word cloud activity is all around Stress Awareness Month. So it's in reference to what brings you joy outside of work. Hello, everyone. Good afternoon. Thank you for joining us for this month's QTECH committee meeting. We're going to get started in just a few minutes, but please enjoy our marketing slide deck. And we also have an interactive word cloud activity for you all to participate in. And it's all themed around Stress Awareness Month for April. And the question is going to be, what brings you joy outside of work? So stay tuned for the instructions to participate. Hello, everyone. Welcome to this month's QTECH committee meeting. We're going to go ahead and get started for our agenda today. We have quite a few items to cover. First off, I just want to say welcome. Thank you for joining us for April's meeting. April is Stress Awareness Month, so we actually have a fun interactive word cloud activity that is associated with that. I'm going to go ahead and transition to the next slide in our presentation. Just to start out, we do have some webinar logistics for you to participate in the monthly meeting. So by default, you join the session in listen only mode and are muted by default. But to participate in any sort of interactive Q&A, you want to participate via telephone audio, you just have to make sure that you have pinned into the audio for this session. We will also be monitoring the questions panel during the committee meeting, so we could take a look at any sort of questions that you may have for the speakers on today's agenda. And then, of course, this session will be recorded for you to revisit at another time. And thank you for participating. This is just a screen capture of all of the amazing health centers that participate within this QTECH program. So thank you for joining us today. For our agenda today, we have quite a few items listed. We'll welcome everyone and participate in our quick interactive word cloud activity. And then we'll also transition it off to our special guest speaker from the High-Tech Center, Nathan Botts, who will continue our Patient Engagement Learning Collaborative series. From there, we will then transition to Haruk Kasai from the HCN team, and she will provide us some National Blood Pressure Month education. And then from there, we will transition to another guest speaker we have with us, which is Meili Sanchez, the CIO of Health Trace Network, and she'll be covering some information related to the 21st Century Cures Act, information blocking updates, as well as opportunities for Q&A. So one of the fun activities that we had in the lobby was in reference to Stress Awareness Month. So we had asked you all to participate in our word cloud using Poll Everywhere. I have the instructions listed on the screen in order for you to participate. So in order to participate, you have to have your mobile phone out. Then you want to have a message box and text the number 22333 and send the message QTECH. Once you have done that, you have joined the QTECH room for today's session. And then you can participate in the live cloud activity we have, but you can also participate in some other polling engagement activities that we have slated for today's agenda. So the question we asked all of you was, what brings you joy outside of work? So let's take a look at some of the responses we got for that. Okay, hold on a second. It looks like there's a lot of reference here on cooking, me time. Let's see. Perfect. So we have exercising, cooking, family time, books, yoga, the beach. There seems like quite a few different options here. A lot of amazing activities and things to help round out things and de-stress during these difficult times. So thank you so much for sharing that. Without further ado, I will now transition to our guest speaker for today's agenda. One of our guest speakers, which is Dr. Nathan Botts, who will continue our Learning Collaborative series so that we are able to continue our discussions on electronic patient engagement tools and completing an ROI assessment for that. So I'm going to go ahead and switch over my screen so that I could share his presentation.
All right, can everybody hear me okay?
Yes, we can.
Sound check. Okay, great. All right, well, thanks everybody. Glad to have you here, and thanks so much to the HCN team for getting us all set up. Hopefully most of you were able to attend the first session in which we were somewhat setting the stage for electronic patient engagement and talking about activation and engagement factors and how we can identify that within our patients and what it means, in terms of shared decision making and getting patients more engaged in self-management activities. And so in this next session, we'll be talking about the different assessment tools. We did a little bit of an overview last time, looking at a couple different measures, and I'll touch on those shortly. And then we also wanted to just generally talk about doing a return on investment assessment for the different types of electronic patient engagement tools that you might want to use. And an important point of that is that that's not something you should wait to the end to start planning on. You want to start planning your ROI from the very beginning. And then we'll be taking a look at a few different tools and some resources that the HITECH Center has put together in order for you to be able to assess the different tools and apps that are out there. All right, next slide, please. And so hopefully most of you are familiar. So I'm from the HITECH Center, and I technically work with the company called WESTAT. HITECH is a partnership between JSI and WESTAT. And the HITECH Center is a HRSA-funded national training and technical assistance partner. We provide trainings across these 10 plus topic areas on the right. We do so through a national website at hitechcenter.org, where you'll find all these materials that I'm going to be going over with you. And we also do these learning collaboratives, obviously, that we're doing right now, remote trainings and on-demand technical assistance. And so please reach out to us if there's anything we can assist you with. The learning objectives for this particular session is to increase awareness of current policies and regulations that require and or impact the use of electronic patient engagement technologies, to be able to look at the different methods of effective adoption and implementation, and then to assess how well you are able to do that, and whether you are providing a return on your investment, whether it's actual cost benefits or cost avoidance. All right, next slide, please. That's me. I introduced myself last time, so I'll buzz through this slide, but electronic patient engagement is a field that I've been dedicated to for a long time, specifically within FQHCs, and used to be a CTO and founder for a product called Health ATM, and a lot of my background came from working with FQHCs on electronic patient engagement activities. All right, next slide, please. So assessing electronic patient engagement needs. Next slide. So our first piece here would be to do a poll. And so the poll is asking, what is driving your adoption of electronic patient engagement tools? Is it that your patients need tools to help them succeed in health improvement? Is it because the lack of staff or time or capacity to address patient needs is limited, and so you need these tools to help bolster your services? Is it due to policy and regulations, such as right to access or information blocking that will be covered later on in the agenda? Is it because it came packaged with your EHR, and so, okay, well, I guess we'll use that? Or is it that your patients are asking for easier ways to schedule appointments or things like that? Or not so sure, maybe you just know that it's something you should be doing. So if you please respond to the poll. And do they type A, B, or C, or do they have to type the whole thing? I think last time they had a little option.
It would be A, B, and C, and I'm actually in the process of moving over the activities, so give me just one moment.
Okay. This gives all of you some good time to do some hard thinking about what drives your adoption. All right, Okay, so we have some pretty good distribution so far. Yes, well, obviously if we're talking about electronic patient engagement as it relates to patient portals, oftentimes those are part of EHRs. Vendors have been pretty well pushed to do so. Lack of staff time, that's important too. There's so many things that we have to take care of with our patients nowadays. It can be very hard to have dedicated staff who are able to do all that on their own. And so one benefit of these tools is it increases our opportunity to engage more personally and more tailored with more patients. All right, thank you for that. So we covered patient activation and engagement. They're highly related, but a little bit different. I won't go through that specific content again, but it is to say that part of activation is really determining where patients stand in their level of activation, which then informs the degree of engagement that can be expected from them. And of course, what we're always trying to do is increase activation levels, making them really feel as though they have an ownership in their healthcare and are, believe they have opportunity to improve it, and thus become greater engaged in their care with their care providers. Next slide, please. And we looked at this last time as well, in that some of these tools that we use, we can then determine what buckets our patients fall in. And this crosses over into our ROI statements, in that your high need patients, with a low level of activation, maybe they have low e-health literacy or general literacy, well, then some of these tools might not be a great fit. And so you might put your energies elsewhere for those types of patients. Whereas then your lower need patients who are highly activated, have high e-health literacy, general digital literacy. These are probably a majority would be our younger crowd, of course. That then there's some opportunity to use these tools because they don't require the same level of handling. And so really understanding where your patient population sits based on your electronic patient engagement strategies is incredibly important. Next slide, please. So the first thing that you want to do when you're kicking off such an effort is to determine why, right? Of course, we have some policy related considerations for providing right to access, right? Things like that. There's great opportunities. A lot of these tools are being made available to us. And so, okay, let's try it out, right? But really, in order for us to better understand whether we are getting a return on investment for our electronic patient engagement efforts is, establishing the criteria for why you're doing so. And so the first thing you want to do is establish your problem statement. And so an example would be our patients are not coming back for follow-up tests like pap tests, colorectal cancer screening, etc. Your denominator would be the number of patients for whom PAPs, etc. were ordered, and then the numerator will be the number of patients who did not return for follow-up. And so, with this initial set of data, you're able to then start thinking through how you go about solving this problem. Likewise, we all have that goal of addressing patients with A1Cs greater than 9%. And so our denominator are the patients 18 to 75 with diabetes with a visit during the measurement period, and our numerator are the patients whose most recent A1C levels performed during the measurement period are greater than 9%. And so, okay, We want to have an impact on this particular cohort. We want to be able to decrease their A1Cs level. And so given that, what do we do, right? But now we've established the problem. We've established the very specific thing that we're going after. It doesn't have to be, say, specific to health. It could be simply increasing communication with our patient population. You know, you don't feel like you're well enough in touch. And so maybe it is only to want to increase the level of communication with your population. All right, next slide, please. So once we've established our problem statement, then what we want to do is what we call the gap analysis math. And so this is about what I call the optimals subtracted by the actuals provides us with the electronic patient engagement gap. And so our optimals are to have, right, you know, a decrease in the number of patients with A1C levels greater than 9%. The actuals is whatever percentage they sit in now, right? And so the difference between the two of those is then your project, right? It is then the target of that thing you're going to do that you think an EPE tool would address. And the important part about this is, and I know we don't always have the option to be so picky choosy, but even if you talk about a patient portal has many different features to it. You might be using this to determine which features you're really going to target and try to use to their best benefit. And so whatever your gap ends up being, this is helping determine what is needed to address that gap. And so maybe it's appointment reminders, maybe it's medication reminders, maybe it's you know, care plan messaging or reminders of care plan goals, you know, depending on what one of those things are, or increasing communication, then you start to try to determine what is going to be the best tool to accomplish that goal, right? So often we might take tools and then we're trying to make it fit something, and it might not be the best fit depending upon our objectives, depending upon the levels at which our patients sit, and depending upon the population or right, the demographics of the patients that are most impacted. All right, next slide, please. From there, then we're defining our target audience, and we had done that a little bit below before in terms of, say, if we were talking about the decrease in A1Cs greater than 9%, then within that still encompasses a broad set of people. And so we might want to even target a much more specific audience. And so, and this again gets to your opportunity to achieve better return on investment. And it's not to say that you're trying to, you know, it's the term, you know, cherry pick, right, for the perfect cases. Of course, you want to have the greatest impact, but you also need to make sure that you're not coming away with bad results because of a bad fit. And so you want to identify a target audience that is the best target given the problem that you have and the tools that you have available to you. And there's a number of different links there. We'll provide them in the slides. It looks like one of the links didn't get hypered, and so I'll make sure that's done. But several of these help us determine our audience, determine their needs, determine their makeup, and from there, you know, allow us to better focus our EPE intervention. And just to confirm, when I say EPE, I'm saying electronic patient engagement, or the acronym for it. And then the HITECH Center's developed out electronic patient engagement framework that walks through these activities and how to conduct them. Next slide, please. We looked at this, we looked at the FOG behavior model, which we talked about needing to have a motivation, ability, and a trigger. And this gets right into kind of determining the causes and drivers for the current behaviors of our patient population or our cohort, right? And so at one level, it might be that they simply do not have the skills and knowledge to do it. Maybe it's doing their testing, or maybe it's education around assessing foot health or things like that. And so one cause or driver for not having that particular outcome might be a matter of skill or knowledge. Could be a matter of motivation. Maybe they're not really understanding how it will impact their overall issues. This can be difficult with patients with comorbidities, of course, because there's lots of complexities to it. But ultimately, if we can find a way to identify value for them, and right, it may not be specific to, say, decreasing some aspect of their ailment, might be more about some other part of their life that they want to be more proactive about. And so figuring out what that motivation is, giving them the confidence to do it, will help us move along that curve. Of course, environment, we know this with social determinants of health is incredibly important. And so understanding more about their environment tells us more about what might be getting in the way, whether it's having the right tools, having enough bandwidth, things like that, or simply having enough time, right? Busy people, busy lives, taking care of others, things like that, or just general social capacity, feeling as though they can engage at the level needed to do so. All of these, the more we assess, the better we have an idea about it, right? The better opportunity we have for behavior modification. And then, of course, attaching that to incentives, whether personal, societal, financial, all of these can have their own impact. We've found, plenty that it takes a mix at times, and that some incentives tap out at some point, and you need to look to some other incentives to keep it going. And so all these are going to help better determine, again, the right tools and fit for the patient population you want to work with. Next slide, please. All right, so now we've put together how we're determining the patient group that we're going to work with, who we're going to target for the particular goal that we're working on or intervention that we're working on. And so now we're going to think through how we then one, kind of assess the broad needs and factors that are going to impact the use of a given tool. And then we talk about how we determine how we're going to report out on the return on investment. How are we going to actually identify whether we have or have not been successful, and where and how much, right? All these pieces require planning and an outline in order for us to realize it, or make sure that we're going to have the data available to determine it. All right, next slide. All right, so next poll is, how do you evaluate the effectiveness of your electronic patient engagement implementations? So let's say a patient portal, we'll keep that simple, or a text messaging effort, or a mobile app maybe that you're using with your patients. What are you using to evaluate progress? Is it frequency of use by patients? Is it something related to patient satisfaction? Is there some sort of population health outcome that you're using to determine? Are you doing some sort of cost benefit, cost avoidance analyses, some other evaluation methods, or maybe you're not working on them just yet, but you want to. So I believe poll will be set up.
Yes. So the poll is active, and then if you already have the QTECH chat box open within your smartphone, then you would just select the options either A through F, as you see on the screen right now.
Mm-hmm. And obviously, there's no right or wrong to any of these. All of them can be important measures. All right, great. So we have a lot looking at actual frequency of use. And of course, this is important, helps us better understand adoption. Some of that, right, frequency of use, frequency of people who return, all these types of analytics, help inform whether patients are able to use the tool, access them, or are finding value from them. Of course, patient satisfaction surveys. There's ones, right, related specifically to patient experience. Some are related to the actual system use and usability. And so there's many different methods to do that. Certainly population health outcomes can provide an indicator as well. No cost benefit style analysis, so which is good, but we'll be talking about how we get to that point, of course, and we had some examples last time looking at cost benefits of rolling out text messaging efforts. Some are using some different methods, and some are planning to get there. All right, great. Thank you so much for your responses, everybody. So I won't go through all these bullets. I know there are a lot here, but it is to say, and this was a big part of our work, was in developing out what was called the electronic patient engagement adoption framework. And it's really just highlighting the socio-technical model, right? That for any one of these efforts, it includes the user, it includes the technology, it includes the organization, and it includes related policies and regulations. And so it is to say that every one of these pieces have their own variables or constructs, and then every one of those variables or constructs are then going to have their own factors that are going to have an impact, whether as a barrier or whether as a strength. And so a part of this, and a part of when we're talking about then return on investment, is to identify the fact that you might not see the frequency of use that you want, but it might not be your patients, right? It could be the technology. It could be an organizational issue. Maybe somebody didn't get a training and they're not answering questions for patients that need to be done, or they're not doing a registration process correct. Or it might be a security or privacy issue, right, that is keeping that thing from working effectively or being able to be rolled out at all, right? And so this is just to say that, looking across these factors, you may not know, if you're not trying to break those pieces down, where you're having barriers or failures in a rollout. So, it might not be actually a failure. It might just be a technical issue that got in the way. And so, it's important to identify all these factors that come into play. All right, next slide, please. And so how do we ask those questions? And so when you are then determining your approach and your implementation and the training and all the factors that come into play as you roll this item out, you'll be wanting to ask questions within each of those categories, and we provide some examples. So the user question is, okay, you've got this great tool, you've got a new great health app out here. How exactly is it going to assist our patients in diabetes management? What are going to be the barriers? Does it have language support? Are there cultural issues that need to be taken into consideration? Is it easy for people with less than nimble fingers to use, or bad eyesight, or right? All these factors come into play, and of course, the makeup of your patient population is going to tell you more about whether it's a good fit or not. Obviously, what they want, right? Those are important aspects. Then the technical aspect, and we know these are myriad and and deep. They're getting better and better at plug-and-play style applications, but certainly within every organization, there's can be technical issues, whether it's just general infrastructure, cybersecurity issues, of course, are huge, and just overall technical staff available to help solve those issues. Next slide, please. And that taps over into organizational issues. Do you have the staff, the time to support the activities? Do you have the finances to support the activities effectively? We all know that funding can be critical when rolling out these types of tools. For staff time at the very least. And then we touched on the policy questions. And so all these would come into play, and all would be questions that you should be asking as you're looking to implement a tool. Next slide, please. So then you need to ask these questions of, so how are you going to determine whether you're achieving the desired results? And so a few people in the poll put patient frequency. And so the question, and which is great, but the question there is, what level of frequency then is going to determine success? Maybe this comes from the CEO or the CIO, and they say that, well, if we see, 30% of our registered patients accessing the site, then we're going to call that success. And so, right, of course, you need to establish a benchmark in order to determine whether you're achieving your desired results. And then what are the specific measures that can be used to do that? And so frequency, right, that's pretty straightforward. Analytics, of course, if we're talking about whether the patients enjoy the experience, then we need to get to some level of satisfaction, perhaps. Frequency, maybe you say, well, frequency tells us whether they're enjoying it or not. And then how are you going to report out on this data? What frequency are you going to plan to report out on it? And do you have the capacity to be able to do that, right? And so all of these help you better realize whether you're actually getting your return on investment. Next slide, please. And so, some key electronic patient engagement evaluation questions, and this is looking at the broad implementation, is what is the purpose? And we covered that. Why are you doing this? Have a specific reason of why. It can be broad. Of course, the more refined it is, the better opportunity you have to evaluate success. Who are your priority clients? We talked about that too. How do we target them? And then based on those clients, what is it that they value? What is it that they are looking to get? What is it they most need? And based on that, right, we're then determining, how we're going to go about getting to that. And so what is the tool that's going to be used? What parts of it are going to help? And then given all that, what is your plan to achieve those goals, right? And this comes from, Peter Drucker, a very well-known organizational business science thought leader. And so this really applies to any business, but certainly applies to the business of increasing electronic patient engagement, or patient engagement via electronic means. Next slide, please. Oh, no, always goes so fast. And would you punch forward a few? I won't spend, there's a few more. Yeah, thank you. I'm going to move past this, but it is to understand, right, that there's different types of measures, and then there's metrics, right? Measures are numbers of patients, whereas metrics are things such as percentages, engagement rates, averages, etc. So there's distinction, and depending upon what you're trying to measure, will depend on what you use. Next slide. Through those. I'm going to slide past this because I do want to touch on a couple assessment tools, but these will be provided in the slides, and these are provided in detail on the HITECH Center site, and breaks further down the process for conducting evaluation of the performance of the efforts that you work on. Next slide, please. And then this is very well known in public health, is development of logic models. And these logic models kind of help you understand where you sit in the phase of rollout, and the expected data and the ability to report out on that you have. And so when sometimes you might simply be trying to evaluate the process of doing something, right? And that will have different factors. If we're looking at outcomes, of course, that will have its own set of factors. And then if we're looking at broad impact, right, that will have its own factors and variables. Next slide, please. All right. Next slide. So the High-Tech Center has done a couple different efforts. Let's skip this poll. I think I'm running out of time here. I want to make sure we have enough time for the other presenters. So if we can skip past this poll for now. We put together a patient engagement tool inventory. And so we did some legwork for you, that we know there's all sorts of information out there that provides, reviews of materials. Of course, it's going to be a little bit biased if it's coming from that vendor or not. And so we figured that, the best place to start was actually with you all and the experience that you've had with different tools. And so via a change agent team, of which the HTN group participated, we actually conducted a field survey of different tools that are being used out there. We also utilize Capterra, which does software style reviews and is pretty well respected, and they have some for electronic medical records and patient engagement tools. And so we brought that all in, and we got some feedback from vendors and put together a report. Next slide, please. And so the links are here in the report. This can be downloaded. It has approximately 10 different tools, and it includes patient portals, health apps, messaging services, some of the pretty well-known ones, and a write-up of our findings. Again, some of this came from direct field experience, and then a breakdown of some of the other reviews that we have found. This was conducted about a year ago, so it's still pretty timely and relevant information, to be sure. And then there's the opportunity to add in your own survey if there's a tool that you're using. So we continue to build on this knowledge, and of course, all this is provided for free back to health centers. And so please, it'll be great to hear about your own experiences with particular tools. If you have any questions about it or just wanted to talk about it with someone, you're welcome to email or call us as well. Next slide. And then it was identified that there's lots of health apps out there that are not actually certified. If they're a particular class of device or software style app, they're not regulated by FDA. And the Children's Health Fund had identified a patient safety issue when a health app that was based on adult measurements was then provided to a child or suggested by a provider for a child, and a safety issue came into play. And so we developed out a decision tree in determining whether a health app is appropriate. And that first one was a poster. And then we, based on some of our own experience working with health centers, we did the next phase of development of the decision tree. And then working with the HL7 mobile health work group, and I'm a co-chair of that work group, and a sub-project called the Consumer Mobile Health App Functional Framework. We further built out the decision tree for the Health App Analyzer. Next slide. And so this is the service that we provide on the High-Tech Center site, and you can use that link there. Again, we'll provide the presentation for you all. And that link will take you to an analyzer. And when you'll work through a set of questions, and based on your responses to those questions, they're asking questions about the app that you want to use and your knowledge around it. And then based on your answers, you are provided with a report. And at the very top there, you see there's a trust level. And the report's broken down into different sections that include aspects such as privacy and security and organizational policy and some of these other factors that we discussed. And so it kind of gives you a general, good housekeeping seal of whether this was the best app or fit for your particular population. And of course, we continue to gather those results and aggregate them across the same types of apps. And so it's meant for all types of apps, whether used with your EHR or simply a consumer-based app that one of your patients is interested in using. And so please check it out. You'll get an emailed report, and you'll receive a digital badge noting your participation as a health app analyzer. Next slide. And we're at the High-Tech Center, hightechcenter.org. Please visit us there. We'll have 2 more in this series, further looking at electronic patient engagement and opportunities to increase activation of patients. And so I hope to see you guys at the next set of the series. Next slide. And that's it. Please reach out to HCN if you have any questions that I can answer for you. If anybody, I didn't see any chats go by, but if anybody wanted to open up their mic now or chat in a question, by all means, please do. And thank you.
We'll go ahead and give everyone just a few minutes if they'd like to participate by asking questions within the chat or raising their hand or unmuting the line. But thank you so much for your presentation, Nathan. There are a lot of great resources in there, and I learned something new with that health app analyzer. That was a really great resource to see how the decision tree works in progress. So thank you for sharing that.
Yeah, thank you. We're just rolling that out. No, and I should note, so I forgot, we'll actually be doing a broad presentation of the HITECH Health App Analyzer on, let me get my calendar up here real quick. So I can make sure I get this right. It'll be next Wednesday at 1 p.m. Eastern. You can sign up for the webinar on the HITECH Center site. And if you have a question or can't seem to find the registration for it, by all means, send me an email. But we'll be going into detail on the Health App Analyzer and you know, how it can be of a benefit to your health center. All right, thank you.
Perfect. Thank you so much for your presentation. I don't see currently any questions in the chat, so I'm going to go ahead and move to the next topic within our agenda today. So we have Haru, who's actually going to talk to us about National Blood Pressure Month education. So if you may not know, May is actually National Blood Pressure Month education. So we wanted to make sure that your teams were aware of some key educational resources in reference to that. So Haru, the floor is yours.
All right, good afternoon, everyone. So as Steffi just mentioned, May is National High Blood Pressure Education Month. So we wanted to share some, some educational topics around blood pressure, and also to give you some resources. So if you move on to the next slide, and the next slide. So I wanted to start out by just sharing some facts about hypertension. This is, as most of you know, is one of the most common chronic conditions seen in primary healthcare settings. If we look at our own data, we see that that's probably the most prevalent diagnosis that we see. About 1 in 3 adults do have hypertension, and only about half of them have their condition under control. And in fact, 1 in 3 people with hypertension don't even know they have the condition. It's a leading cause of leading factor for stroke, for cardiovascular disease, heart failure, and kidney disease. And in 2017, hypertension was the primary or contributing cause of death for 472,000 people in the United States. That's nearly 1,300 deaths each year. So, it's a very impactful disease. In terms of cost, the CDC estimates that high blood pressure costs the nation $48.6 billion each year. So again, this is really a very impactful disease, and it's a priority area for HRSA. It's a priority area in our network, and we've been working very hard with trying to improve control, hypertension control amongst our patients for the past several years. But it's always good to, go back and look at what else there's out there and brush up on what we know. The next slide just has a visual of, kind of gives you the impact. So you can see that almost 2/3 of the people that have hypertension, 1/3 are not even aware. That's the red, kind of the maroon color up top. And of those that are aware, almost 1/3 of them are not even being treated. So it's really something that really needs a lot of work, continuing work. Next slide. So one of the factors that is very critical in trying to get patients to control their blood pressure is medication adherence. And medication adherence is, really critical, but only 51% of Americans treated for hypertension follow their healthcare professionals' advice. And adherence to antihypertensive medications is associated with higher odds of blood pressure control, but it is not always done. And not following your medication increases the patient's risk of death from 50% to 80%. So this is a topic that is really, really very critical. I have a little YouTube video here that I found that I thought would be interesting for us to watch together. So I don't know if Stephanie, if we can just play that. It's very short. I'm not sure if everybody was able to hear that. I didn't quite get to hear what they were saying, but you can. This is going to be hyperlinked on the presentation. You can hear it if you were not able to hear it. But generally, the gist was, even with those patients that do have insurance, it was saying that a lot of them are still not adherent to their medications, and it was making reference to the fact that medication not adhering to their medication regimen is actually more prevalent in the South. So really interesting information there. Next slide. So this is not specifically regarding hypertension medication, but just medications in general. So this has really an impact, this particular slide. When we talk about medication adherence for most of our, chronic conditions, the percentage of people who actually fill their prescribed medications and continue to take them properly and fill their refills, as you can see from this chart here, is it just keeps dropping off. So for every 100 prescriptions, only 50 to 70% actually go to the pharmacy, only 48 to 46 come out of the pharmacy, and 25 to 30% are taken properly, and 15 to 20 are refilled. So this is a topic that really we want to pay attention to, not just with hypertension, but with any of our chronic conditions. Next slide. So what are the predictors for non-adherence? It's important to know what signs to look out for to kind of predict which patients may have issues with adhering to their medication. The first one is limited English language proficiency or low literacy. That's one of the predictors. Having a history of mental health issues, depression, anxiety, or addiction is another predictor. People who don't believe in the benefits of treatment, or who believe that medications are not necessary or actually harmful, those are also people that probably may not take their medications as prescribed. Anyone who has a concern or about the cost of medication or the side effects of medication, these are also indicators. And people who say they're tired of taking medications, I think I lump that together with maybe people who believe medications are unnecessary or harmful. So all of these are indicators or predictors of people who may not be taking their medications properly. Next slide, please. So what do we want? What can we do about it? There's a few recommendations. The first one is to simplify the regimen. And then this includes things like encouraging use of like the days of the week pill boxes, so that people can remember to take their medications on time. Try to match the action of taking the medication with some of their daily activities. So maybe taking it, right before bedtime, or take it with breakfast, or right after lunch. Also, things like, prescribing 90-day medications instead of 1 month. Those are things that help to simplify the process of actually getting the medication and then remembering to take it. Write down their prescriptions clearly, but then reinforce it verbally. Some people may not be able to read properly or have difficulty with how it's written, so always reinforce verbally when you give a prescription. And you can provide them websites for additional reading and information. We can give handouts on the medications. All of those are helpful. And when patients are taking it properly, reinforce that activity, reinforce and incentivize if possible. You should also be talking to your patients to understand and address any concerns that they have. Next slide. It's important to communicate with the patient. Sometimes, we're all rushed because there's a certain amount of time that we have to deal with a patient, but research has shown that most patients will talk for no longer than 2 minutes. So please allow them time to ask and to share their concerns. And also, when you're prescribing medications, you can ask for the patient's input when discussing and recommending, so that they feel part of the decision. Always remind the patients that they can come to you for any questions that they have. And try and understand the predictors of non-adherence that we just discussed, and address them as needed with the patient. Ask them specific questions about their attitudes, beliefs, and cultural norms related to taking medications. That might really give you answers or a way to try and talk to the patient about sticking with their prescribed regimen. Next slide. The last thing that we need to do is also, to adhere their adherence. We cannot just, just prescribe the medication and then assume that they're taking it. Ask them simply and directly, are you taking your medications on time? And let's use simple language. It's not, are you adhering to your medications? It's like, are you taking your pills on time? So that is very important. Then there are some medication adherence scales that are available online. I've listed some of them. You can always Google and find them. So these are, little tips that will help you with helping your patients stick with their medication regimen, which is really critical to, proper blood pressure control. All right, next slide. Now I'm going to turn to a different topic, and this is more education for us at the health centers. And I know we've talked about this in the past, but it's always good to have reminders. And it's also recommended that these topics are covered with your staff and your support staff, periodically, retraining, making sure that it's being done, and not only training, but then evaluating that this is being done properly. The determination of blood pressure is one of the most important measurements, but as we've seen in the slide before in front of us, is one of the most inaccurately performed measurements in clinical medicine. Next slide. So that's where we start. Accurate measurement is the first step in management of hypertension. Next slide. So what can we do to make sure that we are taking accurate blood pressure measurements? So the first thing is making sure that the physical environment is conducive. That means that you have a comfortable room temperature. Having the room too cold can actually lead to false low readings. So we want to make sure that we have a comfortable temperature in the room. We need to make sure that there's the chair so that they can rest their back. Resting their back is critical. You need to have a table so that the patient's arm can be supported on the table and can be level with the heart. If the arm is too low, you can have a false high. If the arm is too high, you can have a false low. So all of these factors are important. As far as your equipment, your blood pressure monitor, it's best mounted on the wall so that the screener can see it at eye level. Actually mounting it on the wall helps it stay calibrated for longer. So that really is important. And the other critical one is cuff size. Ideally you would want to have 4 cuff sizes: the small adult, the standard adult, the large adult, and a thigh cuff. But at a minimum, you should have the standard adult and a large cuff. The most common errors in blood pressure reading measurements are caused by inappropriate cuff sizes. Next slide. With respect to the patient, we want to make sure that we are preparing the patient for the blood pressure reading properly. Patients should be sitting quietly for at least 5 minutes, if possible, prior to the blood pressure check. Their legs need to be uncrossed, their feet need to be flat on the floor, their back needs to be supported, and the upper arm needs to be bare. We should not be taking blood pressures over clothing, and even rolling up the sleeves sometimes can cause constriction. So if the shirt is tight, it is better to ask them to remove it than do it that way, because you're not going to get an accurate reading. You should always try and do the blood pressure reading on the same arm. The first time you should do it on both sides, and the arm that you get the highest reading should be the one that is used for future readings, and you can inform the patient that, so that next time they come, when you ask them which arm should we do it on, hopefully they'll tell you the one that should be used. Having caffeine in the last 30 minutes can affect your blood pressure reading, and even having a full bladder can affect your blood pressure reading. So we want to make sure that we make sure that your patients have an empty bladder, and hopefully they've not had caffeine or smoked in the last 30 minutes. You need to position the arm so it's relaxed and resting on the table, palm up, and again, you have to have it at heart level. And very critical, the patient should not be speaking while you're taking the reading, and you should not be speaking to the patient at that time either. Okay, next slide. So here I'm just giving you a little table that shows you the effects of some of these things that we've talked about on the blood pressure reading. And as you can see, some of them are pretty large. A cuff too small can affect your systolic reading. It can inflate it by 10 to 40 milliliters of mercury. So that's a huge difference. And the cuff too large can reduce it by 5 to 25. And you can see the rest of them. The bar, if patient in pain is also significant towards the bottom. Patient talking can increase the blood pressure between 10 to 15 milliliters per mercury. Next slide. Here's some more. Full bladder can increase the blood pressure 10 to 15 milliliters per of mercury. And the white coat syndrome. White coat syndrome, again, we know that it's that fear that people have, and it drives up their blood pressure before they see the doctor. What we've always recommended is that if you have a high blood pressure reading, you should be doing it a second time. Allow the patient to rest a little bit and let them do it again. If it's still high, we have some centers who actually wait until the patient sees the provider, finishes with their visit, and then they'll take it again. Because usually by that time they're done with their visit, that anxiety level has gone down, and sometimes you can get a more accurate reading after their actual time with the provider. Okay. Next slide. This is a visual that can be downloaded. Target BP actually recommends that you have this posted in your exam rooms. This is a good reminder for whoever's taking the blood pressure. And I'll tell you a little story. One of our centers told me they had this poster in one of their exam rooms, and the MA went in and started doing a blood pressure check on one of the patients. And the patient was looking at the chart and turned around and told the person, "You're not doing this right." Because I think the person was on the exam table, kind of back wasn't rested and stuff. So really powerful. So this is definitely a recommendation to have these signs posted in your exam rooms. It's very helpful. And next slide, the next two slides, I'm actually providing you with a whole lot of resources. These are really great resources. I've looked through all of them. There's a toolkit from healthit.gov for improving the screening, prevention, and management of hypertension. Million Hearts has a lot of tools. Their change package for hypertension control is excellent. We've been talking a lot recently about self-measured blood pressure, which is becoming even more important now. With a lot of patients are being just seen in telehealth. And so Million Hearts has a guide for self-measured blood pressure monitoring. I've given you the link right there. AMA has a 7-step self-measured blood pressure quick guide. This really can be helpful to help the patients achieve and maintain their blood pressure goals. It's a nice little resource right there. The BP technique quick check, that's a little tool that Target BP has, and that's a tool that you can actually use for monitoring your staff. Once you do the education on proper blood pressure taking techniques, you should be evaluating. So this allows us a little checklist that you can use to observe and put down your findings. It's asked certain questions of, was this done properly, etc. So that can be used in evaluating your MAs as they're doing their as they're taking blood pressures on patients. Next slide. A few more resources. So the CDC has a lot of, as well as Target BP, a lot of handouts that you can actually give to patients. They also have a nice blood pressure communication toolkit, a lot of information in there. And then I just added 3 samples of logs that patients can use for their self-monitoring that they can jot their blood pressure measurements on. So there's a lot of information in these resources. There's a lot more out there. So please take advantage of these that I've shared with you and share this with your staff as we honor May, the National High Blood Pressure Education Month. Thank you.
Thank you so much, Haru. I'm taking a look at the chat right now to see if there's any questions that have come in. I currently do not see any, but thank you so much for taking the time to share some of these awesome resources and get our health learners prepared for their honoring of National High Blood Pressure Month. So thank you so much.
Thank you.
Perfect. So I'm going to go ahead and transition to our next agenda item that we have. And some of the things that we focus on within the QTECH grant are related to interoperability. And one of the things that have come up recently is in reference to the 21st Century Cures Act. So we actually have Mamie Sanchez, our Chief Information Officer from Health Choice Network, with us. And she's going to talk to us today about things that we should know about information blocking and how to prepare for these changes. So Mamie, the floor is yours.
Thank you, Stephanie. Can you hear me okay?
Yes, I can.
Great. Thank you so much. And thank you all for having me. As Stephanie mentioned, I do want to share some information regarding the 21st Century Cures Act and information blocking rules specifically that went into effect on April 5th. Next slide. So the 21st Century Cures Act went into effect, or was signed in 2016 by President Obama, and the goal was to provide patients access or better access to their health information. It also moves the healthcare system to be to provide greater interoperability and to make sure that data is shared in order to improve health outcomes for patients. Next slide. This is a timeline of the information blocking rule. The first real component of it went into effect on April 5th. And the main area was to provide electronic health records in specific areas to patients and to be able to exchange that type of data with healthcare providers that are involved in patient care. Next slide. So what is information blocking? Information blocking is a practice of interfering with the exchange or use of electronic health information. Blockers, or actors as they are sometimes called, can be health information technology developers, vendors that provide EHR data, health information networks, health information exchanges, or healthcare providers. On April 5th, as I said, the information blocking provisions of the Cures Act did go into effect. And if someone does think they have been blocked from information, they can submit a complaint to the ONC, and the CMS is also involved. If a practice is determined to be conducting information blocking, that practice or provider may be subject to monetary penalties, disincentives from CMS as well. So it is something that they are looking at seriously, and they are monitoring very closely. Next slide. What actions are information blocking? This is an example of some of them. Having an overly restrictive policy, meaning you have to have a physical signature for patient consent before sharing any data. That is considered information blocking. Limiting technology, and that means not providing the availability of EHR data or specific patient data that would not provide data sharing with other systems or patients themselves. Having an unreasonable delay to respond to a patient request for information, and not having the ability to provide electronic health information in the format requested by the patient or the healthcare provider partner. Implementing health IT in non-standard ways that will not allow for easier interoperability or for overly excessive manual processes to be able to exchange data. Next slide. There are specific data elements or categories of data that are that fall into the information blocking rule that took place on April 5th. And this is basically a subset of your electronic medical records. And the categories here denote what are the specific contents of these specific areas that you must provide electronic access to. Next slide. This has been published. I also provided a link to the document that speaks to the specific data elements that are supposed to be provided. This goes into effect from now until October 6th. Only those categories that are listed in this document will be required. After October 6th, it will be all electronic health data that will be required. If you notice, there is a specific area around clinical notes, and so you need to pay special attention to that, because that does speak to specific clinical notes and information that must be given as part of the medical record. Next slide. Now, there are exceptions to the information blocking rule. There could be information or data that may not be provided in the way that the patient or the partner requests it. It may not be available at all, or it could cause a risk if you do provide that data. So fortunately, they have listed 8 specific exceptions that you can fully document to satisfy the information blocking, and you will not be penalized. I'm going to go into detail on each in the next slide. So the first one is called preventing harm exception. You must satisfy these key conditions. What that means is that if you share particular information that has been requested, you could provide a risk to harm to a patient or another person. In order for you to satisfy this exception, you must meet this criteria that's listed here. I also provided a link that speaks to some of these and examples of these as well. Essentially, you must be able to document all of these exceptions and in particular substantially explain why you would be introducing harm by sharing this data. It must satisfy at least one condition, whether it's the type of risk, type of harm, and if you implement the exposure to this data, it would bring harm to the patient. Next slide. The other exception that is considered is called a privacy exception. There are key conditions that need to be met in order for you to use this exception to avoid penalties for information blocking. You will not be penalized if the patient has requested to not share their information, if it will conflict with the HIPAA privacy rule. You also will not be penalized for information blocking if you are working with a health IT developer that is not covered by HIPAA. And also if you have preconditions that are required by state or federal law that have to be satisfied in order to provide access to the data. Next slide. The security exception means that if you share this data, you will compromise the security of the electronic health system and electronic health data. You can satisfy this exception if you document specifically why, if you use this standard across the board for all requests, and if you tailor it to specific security risks. You must have an organizational security policy in place in order to qualify for this exception as well. Next slide. Many times in our electronic health record, we just don't have access to the data or are unable to provide the patient access to the data. That's when this exception really comes into play. Again, fully documented. Everything must be documented, and you must provide a response to the requester within 10 business days of the reasons why you cannot provide it. There are some of these, some criteria that will be required for satisfying this exception. As you can see, if you have a natural disaster, a public health emergency, war, etc., natural events that are uncontrollable will satisfy this exception. That you cannot carve out the data that has been requested without exposure or risk to any other data element. And then if it's just not available within the system to provide. Again, must be fully documented and used as a standard for all of the same type of requests. Next slide. There's also a health IT performance exception. Many times our system has to be taken down for maintenance. If you request specific information, it may degrade the performance of the system. And those are exceptions that you must document. Again, every exception must be fully documented and used as a standard across the board. But you can show the expected service level agreements that will take place. If it is longer than expected, you will be information blocking basically. So you must document the expected downtime and the outage that you have agreed upon, and that you do make sure that your third-party vendor or your EHR vendor has given you enough information to be able to satisfy the exception documentation. Next slide. There's also a licensing exception. If you have requested data or have a partner request data from you, and you do require licensing in order to release the data, that is an exception, but you must begin licensing negotiations with the requester within 10 business days from the request. And you have to have a license procured and in place to the requester within 30 business days of the receipt of the request. Again, this must be non-discriminatory, which means across the board for every type of request, and has to be within the scope of rights for the license. Next slide. There has been some question around, are you allowed to charge fees for data access and data exchange? And you can. The condition is that you must to all requesters across the board and not have a bias, whether the requester is a person or a vendor that is in competition, in direct competition with you, that it is satisfying the need for costs to provide the type of access, and that it is, again, complying with the conditions of the certification that are related to the request. Next slide. Now, there have been times when, or if a patient asks for access, electronic access to patient data, such as the portal, and you are not able to provide it, however, you can provide it in a different method. You can satisfy the request in a different content or a different manner, as long as you document the explanation and the reasons why you will be doing that. And that will apply to this exception. So it's very important for you to know and cannot provide and the method. And if you don't have the ability to provide it electronically as requested by the requester, you must document and explain and have in place the alternative manner and content that you will provide the information. Next slide. So what do you need from your EHR vendor in order to satisfy the information blocking rule? You should absolutely review your portal. Make sure that all of the core data elements are available and accessible. If you need to enable access to the data elements from your EHR system as an administrator, please make sure you do that. If you are missing access to some, ask your EHR vendor for documentation so you can use that to satisfy an exception, such as infeasibility if it's not available, or content and manner if it's available, however, in an alternative method or fashion. Ask your EHR vendor how you can get to the data using alternative ways, CCD printouts, vendor data requests, etc. Many vendors have a portal that you can request patient data. You need this information because you do have to document to use, again, the content and manner exception here so that you are not violating the information blocking rule. It's important that you know what the timeline is for the 21st Century Cures Act provisions in general, specifically information blocking, because there are further dates and deadlines for information blocking that will happen over the next 12 to 24 months. Please make sure you keep in touch with your EHR vendor and know what those deadlines are, what they're doing, and what their plan and timeline is for complying with those deadlines, and how you can provide information and update your patients on this compliance. Finally, document the process for data exchange that will be needed from your EHR vendor and compare to the rule. If there's something missing, that means that one of your exceptions should apply, and you should really rely on your vendor or EHR partner to give you the documentation that you need in order to satisfy that exception. Next slide. So essentially, you have to be prepared if you are not already. Familiarize yourself with the information blocking definition, criteria, how your business will make changes to comply to the requests and requirements, particularly HIM and patient access information is very critical to review, and make sure that everybody that is patient-facing knows all of the new rules and requirements. There is an ONC frequently asked questions site that I've included at the end that will give you specific answers to information blocking and how you will address that at your centers. Ensure that your staff is trained and manage and monitor for adherence. Usually you want to be working with your risk management, your compliance or privacy officer to make sure that this is done. Make sure that you have all of the proper policies in place, so that everybody is aware of the information blocking rule and what your organization is doing to be compliant with that rule. Make sure your staff, your system admins, and your EHR administrators know what data elements are required and that they enable everything or understand what those exception and documentation needs are for patient requests or partner requests for data. More so than that, you do need to know what those data elements are, and you need to keep in touch with your state privacy laws to make sure that you know what that means for those particular data elements in your particular state. Laboratory results must be provided, and there is some information that speaks to that. I have gotten a lot of questions from many of our centers about that. There is some question around, do you provide it to the patient through the portal before the provider has seen it, or had a chance to speak with the patient? Fortunately, you're not alone in that question. There are a lot of folks that have that, and it's not black and white. There could be a preventing harm exception if certain lab results are released before the provider has had a chance to discuss it with the patient. But again, I highly encourage you to read through the documentation and all of the links provided so that you can be prepared to answer those questions. Remove any filters that block access based on specialty or programs unless blocking is required by state and privacy laws. Now, the HIPAA laws apply and they don't get overwritten by information blocking. There is actually a lot of synergy. Specific sensitive medical information and clinical notes and diagnoses are protected, and they are not considered information blocking if those are the particular pieces of information that are requested. Update your workflows to remove delays in client access to clinical data. You want to be able to provide it as quickly as possible. Although the rule does not give you specific days that is required, it is considered unreasonable delay if they do not have quick access to it. So I highly encourage you all to take a look at how long it actually does take to provide patient data or partner data of patients, so that you develop a policy around that and you establish the rules and guidelines for the amount of time for the access. Take a look at your HIPAA privacy, release of information documents and policies that are posted throughout your center. Make sure that they don't conflict with information blocking rules. That's very important because patients can, again, report a complaint to the ONC if they find a conflict of information in those documents that have been posted. And then finally, review your business associate agreements with your existing vendors and your data sharing agreements with your partners. Even though they have been finalized before the deadline of April 5th or the start date of April 5th, they do fall into the compliance. So please take another look at these documents to make sure they don't contain language that would prevent data sharing and make you exposed and liable for information blocking. Next slide. And then finally, as I said, I do have quite a few references here that you can link on to access information. I also have provided several attachments. One is a checklist that you can go through. It speaks to HIM, but it is a good checklist for general information blocking for your center. And I've also provided a template that can be shared thanks to our partners in Chime, that you can modify and make your own to make sure you establish a no information blocking policy at your center. Next slide. And that's it. I'll have any questions, I'm available. And if you need more information or you'd like to speak with me in detail, please reach out to our HCN QTECH team and I'll be very happy to set up a one-on-one. Thank you so much. I'm open to questions.
Thank you, Maylee. That was a fantastic presentation. Those handouts that you also mentioned are within the handout section of the GoToWebinar, if anyone would also like to download those during the presentation. So that was just so everyone's aware. I'm currently looking at questions within the chat right now to see if anything has come through. And I do not see any questions at this time, but I will help to coordinate if there are any other follow-up items that come from this. So thank you so much for taking the time to present. Perfect. So then that leaves us to wrap up for today's April's QTECH committee meeting. So we just wanted to make you aware of a couple upcoming events that are occurring, one of which is our Clinical Leaders Workshop that will be taking place within the next few weeks, and registration will be closing on April 28th. So please get the word out to any clinical leaders amongst your health centers that would participate in this event. In addition to that, we do have an upcoming Health Center Spotlight webinar session that's being done in conjunction with QTECH. So QTECH and QTECH networks are coming together to host a webinar in reference to social determinants of health data collection and referral to community resources. So we just wanted to bring that to your attention so that you could register for that as well. And with that, we will be closing today's April QTECH committee meeting. Thank you for taking the time out of your busy schedules to meet with us. And we look forward to seeing you all again in the month of May to continue our Learning Collaborative series and our discussions in relation to QTECH. So thank you so much for your time. Have a wonderful rest of your day.